Hello everyone, Dr. Padmanabhan here, and here I am with some issues in the management of old cardiac patients. Old cardiac patients means anybody over 60 years do not qualify. Old means, when I studied public health, people used to say, old means after 50 years, then old means after 70 years. But I think that was in the 70s when I studied public health in Calcutta. But after that, now it is changed. Probably you can say old is after 70 or 75, and old is probably after 85 or 80, 85, because it changes. All these perspectives change all the time. Which brings me to my own personal experience regarding one of my uncles who died in the 70s probably, or the late 60s. He was pretty young. Before 60 years, he had several heart attacks. Then, at that time, this cardiac procedures were not, especially the percutaneous procedures, were not there at all. So the only thing available was probably the coronary artery bypass, and he was taken to somewhere in Tamil Nadu for, I think it was Vellore. Vellore, I think. And he went and coronary bypass grafting, and he did not make it. So people used to say, "Oh, we had warned him. It is a very risky procedure and all that." But nowadays, anybody who is not having a real, real multiple morbidities like whose heart function is not that good, things like that. Otherwise, everybody will make it. CABG is not a very, very, not a very drastic procedure these days. CABG is a routine procedure. If people cannot be taken off of percutaneous procedures, it is one of the invasive cardiac procedures. Of course, even now, that's what this talk is about. Even now, in old people, today there are old. I said after 75, but it is not about age. Age is just a number, as they say. It's about your health. If you are frail is not what the usual meaning of frail. The frail in the sense that frail is equal to your biological age. What's your biological age? If you are 80 years and still you have a good gait speed. Gait speed means walking ability, gait speed, the speed of walking. Good gait speed, and there is no cognitive decline. Your faculties are still there. Like you have no geriatric syndromes. Faults are not there. You are fairly fit. Your biological age is maybe about 65. So there is a lot of difference between chronological age and biological age. So when we say that age is old people and the risk and all that, you have to consider his biological age, which is calculated by his frailty scores or frailty index. There are a few, two, three, or even sometimes more frailty scores. One of the more common frailty scores employed nowadays is what's called Canadian CS HE, Canadian Study of Health and aging. CSHA, not E, CSHA. Canadian, they have got a frailty score is there. It's very easy to consider a frailty score. The people who are extremely fit is called fit. So somebody who doesn't have illness is well, and somebody who has illness but it's still he becomes all right with medication. It's called okay, normal. And somebody who has some symptoms of disease is called vulnerable. So there are 3 scores above vulnerable and 3 scores below vulnerable. Below vulnerable, you have got frailty. That means you will need some assistance in the what's called instrumental activities of living. So there are 2 activities of living. This is daily activities of living, like brushing your teeth, toileting, then able to eat without assistance. Daily activities of living. But there are instrumental activities of living. Means you have to have a good faculties. Like, for example, you have to make your own phone call and go to the bank, probably drive. All this. So if you need some amount of instrumental activities, mild frailty. It's more than that, it is moderate. In moderate means you may not be able to walk without assistance. Instruments, you have to have somebody around you, or you forget something. That is moderate. And severe means you are totally dependent on us. That's why it's a very simple the frailty index. Canadian Study of Health and Aging, frailty index. So that can be incorporated in before making a decision on cardiac interventions. Why do we take cardiac interventions so seriously in old people? This is an interrelated problem. Those who have cardiac disease will have more frailty. Generally, there is another frailty score. It's called Fried phenotype. Although it's written as Fried, Fried, it's read as Fried. Fried is a person. It's a professor of geriatry in Columbia University. Her name is actually Linda Fried. So she has a beautiful thing. Frailty phenotype. Phenotype means, frailty should not be understood as a collection of comorbidities. Somebody having muscular problem, somebody having cardiac problem, somebody having neurologic problem, and all these together, so they are not able to get up. That is not frailty. Frailty is actually equal to senility or a biological age. That means it is more or less related to there is something called sarcopenia of old age, the muscle wasting. So she is related to that. There a frailty score is there. Somebody who has got a lot of exhaustion and very tired, all the time feeling weak because it's not able to get up, not move about. That is three is there. There are 5 scores, and all the 4 is about the movement. That shows that your muscle is wasting. You are having sarcopenia. And the 5th one is unintended. That is even without dietary restriction or without your fasting or anything, you lose weight, or without having a malignancy, internal malignancy, you lose weight. That is about 8 kilos in the last 1 year, more than 8 kilos in the last 1 year. That means you have got all the 5 frailty phenotype. Phenotype means the symptomatology. That is how we diagnose frailty in old people. Frailty is not equal to the geriatric syndrome. Geriatric syndromes are falls, cognitive decline, incontinence, things like that. Falls also entails fracture and falls and fracture, and also this thing. Then The mood disorders also quite common in people having frailty. I mean, geriatric people, mood disorders. But we have to bother about the cardiac, how you can optimize the cardiac risk in these geriatric population. Because cardiac risk involves geriatric syndromes. See, all the geriatric syndromes can be manifested by old people if if they have cardiac failure. See, the three or four common things in old people is old age cardiology is cardiac failure. About 10% more than 80 years will have cardiac failure. Then another thing is coronary vascular disease. It starts from 50s, 60s, like that. It increases. 80% of deaths after 80s, 80% of coronary artery disease deaths are due to, are seen in people more than 80 years. So coronary artery disease. There is another entity which many practitioners are not very familiar with. It's called, there is increased valvular heart disease in old people. That will be around 3% to 5% in more than, it starts from 70 years, goes over 80 years, and and so it becomes very important, especially clinically more important is aortic stenosis. Though the more common thing in valvular heart disease in old people is mitral regurgitation. It does not become symptomatic so much. The mitral valve involvement is more common, but aortic valvular involvement is the one which is mostly treated, because that's the one which manifests the symptoms of either false syncope or cardiac failure, or even cardiac coronary vascular disease because of aortic valvular calcification. Actually, it is related to coronary vascular disease. Coronary vascular disease caused by, as you all know, the disease of the small blood vessels called atherosclerosis. The same process can involve the aortic valve, the cardiac valves also, same process. And which leads to calcification, all the complications. So it's one and the same thing. The cardiac disease in the old, it's a spectrum of coronary vascular disease plus valvular heart disease, plus heart failure. Heart failure is the final arbiter, the final thing when it becomes beyond symptom control. The people develop cardiac failure. The heart does not function. Become cardiac failure, and the cardiac failure affects the kidneys. It affects the lungs. And the untreated, the mortality will be there in 1 or 2 years. That's how many old people die. And it is very much related to frailty. When you have a lot of cardiac failure, it's like you are having frailty. You won't be able to move. You won't be able to get up. And your even cognition will decline. You will be having falls. And in old age, heart failure will present with falls or incontinence, because you are giving a lot of diuretics, or they will have pre-syncopal attacks. Pre-syncopal means like vertigo. So those people having this geriatric syndrome should be evaluated for cardiac function, whether you have to rule out they have got cardiac failure or not. Then another thing is, if the coronary vascular disease, they will also present with non-specific symptoms like this. They will not present with chest pain. Most of them will present with maybe abdominal pain. Sometimes they will present with incontinence. They will present with cognitive decline or mood disorders, like that. So this is you have to the geriatric syndrome itself can be caused by cardiac disease. So this has to be sorted out. So then going on to managing these things, there's a. So did I complete my story? Of yeah, I said he died because he went for an invasive procedure. So there are, but it is not like 1970 or 60. Nowadays there are two or three large population-based studies which has validated these the treatment modalities in old people for cardiac disease. I already said about the Canadian study of this thing, health and aging. And there is another important study. It's called HYVET study, HYVET. That is hypertension in the very elderly trial. That is hypertension in the after 80 years trial. Again, I wish to remind you that 80 chronological age is not important. What is important is your biological age. But anyway, the study was, because the study design can be done only through statistics. So after 80 years, they had a study called hypertension in very elderly trial, HYVET trial. They found that those who had a diuretic, it's called indapamide, plus or without also, plus or minus this one perenropil. Perenropil means it's a kind of this one or ACE blocker, perenropil, like enalapril, like that. So perenropil, they had a lot of improvement or decrease in cardiac mortality and morbidities. So hypertension should be treated even after 80 years. So there is no doubt about it. At the same time, there has been a study on statins, but statins benefits are not seen after 75 years. There is no study to prove that statins give you real benefits. So there is no validation for giving statins after 75 years. But if somebody is on the side, I would say you don't have to continue it. But probably if you are very frail, the risk versus the benefits, every drug has a risk, a benefit and a risk also. Some risk is also there with every drug. So you have to balance it. The risk is more means you don't give that drug. So if somebody develops myopathy because of statin, then you have to stop after 75 because there is not much evidence for that. But a hypertension treatment should be done, especially with ACE inhibitors and diuretics. There is no two opinion about it. HYVET trials are there. This is a positive trial. There are some. There has been the surgeries which old people undergo are coronary artery bypass grafting, CABG, or you can say there is an invasive, non-invasive medical. There was a trial for, it's called a TIME trial, TIME, trial for invasive versus medical in elderly. That is TIME, TIME trial. And there is found that in people not having frailty, a lot of frailty, those who undergo invasive procedures, there is an early mortality, but it is offset by excellent short-term and mid-term longevity. Long-term longevity has not been studied, but short-term and mid-term longevity in the time trial. So if you are fit, even after 80 years, you should undergo invasive procedures. The invasive procedure, I said the first one is the PTCA, percutaneous transluminal coronary angioplasty. The other one is CABG. Both have risks, but benefits outweigh risks even after 80 years. provided the people do not have frailty phenotype. There are, but this is a positive trial. There are many trials, they are all observational studies. I wouldn't say they're trials, observational studies, and which not as many patients as this time trial and the highway trial. Highway trial is about 3,000 patients. Time trial also around that number. But the smaller, this one, studies, observation studies, which has shown that those who undergo, CABG with aortic valve replacement together, or one of the other alone also, they have high mortality rate. Then they have to be dependent and be hospitalized for a long time, even up to 1 year in some studies. So so that is so if the person is not fit, should not be subjected to the fitness is not the physical fitness alone. Yes, saying frailty fitness. I mean, his frailty index should be taken into consideration. If he is frail person, by the Canadian health and health study, if it is the score is above 5 in Canadian health, you should not subject them to these things. Another, there is another score. It's called thoracic surgeon's score. A cardiothoracic surgeon's score is there. If that score is, I went into the net and so, but I could not enter and see what the score. But they have taken a lot of parameters to arrive at a score. If that score is above 15, probably you should warn the relatives that it is too risky. There is another thing. I said probably the surgery will have more risk than in invasive procedure than percutaneous procedures, because surgery entails open surgery. You have to open the chest and do these things and all that. But percutaneous means it is done through the femoral artery or the radial artery or whatever. So it is supposed to have less risk. Aortic valve replacement surgery is called open surgery of aortic valve. It's a big procedure, and it has a lot of short-term mortality. So the people who are not fit, they have devised something called this one. Transaortic valve replacement. It's called TAVI, I think. TAVI, T-A-V-I, TAVI. Transaortic valve implantation for aortic valve replacement. So open aortic surgery versus TAVI, there has been a few studies. As an observational study, and one study had about 1,000 patients involved in it. And what they found that in open versus TAVI, open mortality is they have about 6 to 8%, I think, 6%, around 6%. And TAVI mortality is, immediate mortality is around 4%. Surgical mortality is 4%. But the stroke risk in TAVI is just the reverse. That is, the stroke risk is more than the surgical risk. Stroke risk more in TAVI than in an open aortic surgery. So even TAVI is not without risk, because somebody who is already having a cognitive decline because of his, this geriatric, because of his frailty, then if he gets a stroke on top of it, means it's finished. So it has a poor, medium, Even short term, medium term also, very poor risk profile for transaortic valve implantation. But this is at the present time. This is our the present knowledge. But with the optimization of all this, these are all in the it's not now the developing stage, but it's maybe last 5 years or so. But over the term, all these things can come down. I am giving the results at the present time to give you a little warning on the risk. That's all. But it can improve. These are some of the perspectives on this one. Management of very old cardiac patients. Cardiac patients have a problem. Cardiac, they have more because it's interrelated frailty. They have more frailty than the common geriatric population. So if somebody develops a geriatric syndrome, always rule out cardiac problem, either coronary or heart failure or valvular heart disease. These three things have to be excluded. Anybody having a lot of frailty, because it's interrelated, very much interrelated, this cardiac problem and frailty. Another thing is, if you go for invasive therapy in people who are frail, always be a little wary of this thing, complication rate. The patient may survive, but if he's surviving dependent on others, with lot of frailty, not able to move, what's the point in doing a surgery or replacing a valve, doing a TAVI? It's not. The risk benefit ratio is very low, isn't it? Oh, so that's about it, I think. Thank you very much. I hope we will think about it and convey the message to others also. Thank you very much.